So this was discussed in detail since morning, how dietary patterns affect sarcopenia and chronic kidney disease. Basically, diet is classified in three types. That's a plant-based, anti-inflammatory diet, and DASH diet. They actually preserve muscle via decreasing inflammation, and they have a cardioprotective and anti-inflammatory. And the limitations of anti-inflammatory diet are limited. Direct randomized control trials in CKD sarcopenia are not there. And the clinical use is you can use this diet with CKD with inflammation. Coming to DASH diet, it is an indirect benefit via better metabolic control. It's evidence-based for BP control, but requires to monitor electrolytes like potassium. Similarly, Plado diet or plant-based diet, it supports muscle with better metabolic environment, gut health, antioxidant rich, lower anabolic potential if protein inadequate, but it is beneficial with the metabolic syndrome preference and who have preference to vegetarian diet. Now, these are the studies which showed anti-inflammatory diet, DASH diet and plant diet. The key outcomes were higher dietary inflammation associated with increased sarcopenia, and prevalence was almost 19%. Higher inflammatory index linked to lower baseline kidney function and faster decline over time. Pro-inflammatory diet associated with higher CKD risk and worsening renal function. When there was a low adherence associated with higher risk of progression to end-stage renal disease, and high adherence to protein less diet associated with reduced incidence of CKD and better renal outcomes, and greater adherence associated with reduced CKD risk and improved metabolic profile. So some of the studies which showed the impact of diet on sarcopenia in CKD patients are, they compared a conventional low protein diet with very low protein diet and supplemented with keto analogs. This showed low protein diet with keto analogs stabilizes renal function and slows CKD progression more effectively than diet alone or no intervention. Zemkevanok et al. In 2016 compared low protein diet with the keto analogs, that was 1 tablet per 5 kg per day and adequate calorie intake versus standard care. The study showed combination therapy significantly reduces the rate of decline in kidney function, particularly in advanced CKD, while maintaining nutritional status. Similarly, a study conducted in 2018 compared low protein diet and very low protein diet with higher protein. The lower protein and very low protein diet slows CKD progression and delays dialysis without significantly increasing risk of protein energy wasting. Similarly, a study conducted in 2018 compared the low protein diet with keto analogs, and low protein diet with keto analogs improved metabolic control and preserved nutritional status. Similarly, energy supplementation improved diet adherence, reduced protein breakdown and led to better renal and metabolic outcomes. Recent study done in 2020 by Gonzalez, which showed the intervention was assessment of adherence to plant-based diet using dietary scoring, focusing on its impact on inflammation and insulin sensitivity. The result was higher adherence associated with improved insulin sensitivity and lower inflammatory markers. Some of the study, especially the newer studies with the MDRD study, which showed in nutrition and CKD progression, there was a little bit of concern that sub-study after a long-term follow-up in 2009 showed that there was no delay in kidney failure, but increased mortality risk in very low protein group. In GIST, the evolution of protein intake recommendation in CKD from 2010 to 2024, now at present probably we all agree that around 0.8 gram per kg per day is relatively better. So these are all the guidelines updates which I have compiled in one table, KDIGO 2024, which says 0.8 gram per kg with calories of 30 to 35 kilocalories. Similarly, KDOQI in 2020 showed 0.55 to 0.6 with 25 to 35 kilocalories, and similarly SPEN 2021 ERA and National Kidney Foundation showed almost similar low protein diets. Coming to physical activity recommendation in CKD related sarcopenia, general physical activity KDIGO recommends general physical activity, which encourages regular physical activity in all CKD patients based on tolerance. It improves physical function, reduces frailty and sarcopenia risk. Similarly, resistance plus aerobic training, combined strength training with aerobic exercises, preserves muscle mass and improves functional capacity. Similarly, resistant training 2 to 3 times per week, progressive overload after that increases muscle mass and strength. Combined training, which shows resistance plus endurance training recommended, improves muscle function and reduces inflammation. Similarly, trials conducted and published in JASN and AGKD which showed intradialytic exercises during dialysis sessions improves adherence, strength and quality of life. So these are all the studies which showed improvement of sarcopenia when compared to no exercises. This is the exercise prescription for sarcopenia. Aerobic 3 to 5 days per week, 30 minutes per day or 20 minutes vigorous such as walking, cycling, treadmill. Resistant training 2 days per week, 10 exercises, 2 to 3 sets, 8 to 12 reps, squats, leg press, chest press, band weights might be helpful. Balance training 3 days per week, around 20 minutes per session, heel to toe walk just for balancing, single leg stance and stepping drills. And for flexibility 5 days per week, 10 minutes per session, 3 sets, static stretching upper and lower limbs. Combine aerobic resistance, balance and flexibility training for optimal sarcopenia management is advised. Yes, thank you.